Global Surgery Lab presents a lower limb fasciotomy anterolateral incision crash course. This procedure releases pressure in the anterior and lateral compartments of the leg and must be paired with the posterior medial incision when compartment syndrome is suspected. The basic steps include landmarking, creating a skin flap, locating the intramuscular septum, and opening the anterior and lateral compartments. You will need a knife and curved scissors. To landmark, find the lateral malleolus and head of the fibula. Draw a line between the two. Then, draw a punctuated line 1 to 2 centimeters anterior to the line of the fibula. The punctuated line is the incision landmark. Next, create the skin flap. Make one long incision through the punctuated line. A common mistake is to make the incision too posterior, missing the anterior compartment entirely, so make sure your incision is 1 finger anterior to the line of the fibula. The incision should be 12 to 20 centimeters in length, extending from 3 fingers distal to the head of the fibula to 3 fingers proximal to the lateral malleolus. Once your incision has been made, mobilize the skin to expose the fascia. Next, locate the intramuscular septum between the anterior and lateral compartments using the H technique. Make a perpendicular incision through the horizontal plane through the exposed fascia to make the crosspiece of the letter H. This incision should be a few centimeters long and expose the intramuscular septum. Finally, open the anterior and lateral compartments by sliding partially opened scissors through the length of your incision anterior and posterior to the intramuscular septum. These cuts will form the legs of the letter H. Ensure the tips of your scissors point up and away from the septum, and that the cuts are 1 to 2 centimeters away from the septum to avoid damaging the fibular nerve. Make sure to open the compartments along the full length of your skin incision to prevent the fascia from acting as a constrictor band. After the procedure is complete, do not close the wounds primarily. Leave them open for a minimum of 48 hours. Cover with sterile wet-to-dry dressings that are changed regularly, and consider a shoelace closure.